Caros colegas, é com enorme satisfação que compartilhamos esta aula especial elaborada pelo Dr. Abhilash Koratala, docente do Medical College of Wisconsin e idealizador do NefrUS, website que promove o uso da Pocus na prática nefrológica. O professor Koratala é um nefrologista de prestígio mundial e uma das principais autoridades no ensino e na aplicação da Pocus em nossa especialidade. Atendendo ao convite da SBN, o professor Koratala gentilmente gravou a videoaula intitulada Pocus e Nephrology, an Overview, para marcar o lançamento das atividades do Comitê de Pocus, Ultrassonografia e Nefrologia. Nela, ele compartilha sua experiência e visão sobre como a Pocus pode aumentar a acurácia do exame físico nefrológico, aprimorar o cuidado ao paciente e contribuir na educação médica. É um grande privilégio poder contar com a valiosa contribuição do professor Koratala neste momento tão significativo para a nefrologia brasileira. A sua colaboração aprimora e consolida o nosso objetivo de incorporar a Pocus na prática nefrológica e na educação médica, favorecendo nefrologistas e pacientes.
Hi, I'm Dr. Koratala, also known as NefrUS. In this lecture, I'm going to provide a brief overview of Pocus or point-of-care ultrasonography use in nephrology. This is not a detailed technical lecture, but supposed to give you an introduction to Pocus. I have no financial disclosures. First of all, what is point-of-care ultrasound? It's the ultrasound examination performed at the bedside, that is at the point of care, by the clinician, who is a physician treating the patient, not the radiologist, to answer focused clinical questions. And what are these focused clinical questions? These are some questions that we have in mind after taking good history and completing the conventional physical examination. And answering these questions will either provide the diagnosis or narrow the differential diagnosis. And you can also use Pocus to perform a bedside procedure such as a dialysis catheter placement or performing a kidney biopsy. So procedural guidance aspect of Pocus is well established, and the diagnostic component of Pocus is gaining a lot of traction in nephrology. What are some examples of focused clinical questions? Does this patient with acute kidney injury have hydronephrosis? No matter how good you are at physical examination, you can't answer this question, but if you have point-of-care ultrasound skills, you can answer this question in just a couple of minutes. And does this patient with shortness of breath have pulmonary congestion? Or maybe the shortness of breath is because of pleural effusion, or maybe the lungs are clear and you have to think about alternate diagnosis such as pulmonary embolism. Another example would be you are in a dialysis unit and the patient develops intradialytic hypotension and you wonder if this patient has pericardial effusion. So all these are simple focused clinical questions that we encounter in day-to-day nephrology practice. Over the past several years, Pocus has evolved as a component of physical examination. These are the four traditional pillars of physical examination: inspection, palpation, percussion, and auscultation. Now, insonation or point-of-care ultrasound is considered a fifth pillar of bedside clinical examination. So why do we call Pocus a component of physical examination or an extension of physical examination? First, if you think about physical examination, what is it? It's a process of evaluating objective anatomic findings at the bedside, and you integrate that data into patient's history and clinical context. That's what is physical examination, and that's what Pocus is letting you do. And you can do physical examination with your eyes as an inspection, or hands as in palpation and percussion, or using some bedside tool such as a stethoscope for auscultation. These are all the bedside devices or point-of-care devices we are familiar with, such as reflex hammer, flashlight, measuring tape, stethoscope, tuning fork, and so on. And the sonoscope or point-of-care ultrasound devices have evolved as an additional bedside tool or an additional component of nephrologist's diagnostic kit. So that's why we say Pocus is a component of physical examination. It's performed by the treating physician himself or herself, and it allows immediate clinical decision making. So if you're evaluating a patient with acute kidney injury, what are some focused clinical questions that you have? I mean, the commonest is, does this patient have hydronephrosis or not? And this is how a kidney looks like on grayscale ultrasound. For example, you are looking at the right kidney through the liver. So you have the liver on top, and you have this bean-shaped organ kidney. And in the middle of the kidney, you have this fat that is over all the collecting system of the kidney. If you don't have hydronephrosis, it's all fat you see in the middle of the kidney. But if you have hydronephrosis, you see that as an anechoic, that means black, branching system, because as the collecting system dilates with backflowing urine, that collecting system splays away the fat, and you start to see this black or anechoic branching collecting system, which is hydronephrosis. And you can qualitatively grade hydronephrosis into mild, moderate, or severe, depending upon how much backflow is going into the kidney and compressing the renal parenchyma. So for example, this is mild because kidney parenchymal architecture is well preserved. And this is moderate. As more urine goes back into the kidney, it forms a cauliflower-like appearance, and there is some pressure effect on parenchyma. And this is severe, where the entire kidney is essentially filled with urine with some parenchymal thinning. And it's qualitative, so you can always say, I found mild to moderate hydronephrosis or moderate to severe hydronephrosis. You don't need to bother about giving a specific grade. Just you finding the presence of hydronephrosis versus absence would narrow your differential diagnosis and change management. That's kidney. And you should always look at the urinary bladder too whenever you see a patient with acute kidney injury. Normally, a urine-filled bladder looks like this. So urine is fluid, so fluid is black on ultrasound, and bladder is a thin-walled structure distended by urine. And if you put a Foley catheter and drain this bladder, this is what you will see. So this nice circular cystic thing is the balloon of the Foley catheter that you fill with fluid. That's why it's black. And here the bladder is no longer distended. You have a little bit of urine, but most of the urine is drained. You might encounter a case where the patient has a Foley catheter but not making any urine. Is the next step dialysis? Maybe, depending on the labs and the clinical context, but you should always look at the bladder. Is the Foley draining properly? So we put the transducer in the suprapubic area and look at the bladder in this case. So you do see a Foley catheter balloon, but the bladder is not drained. You see the bladder is distended with urine. So you know that the Foley catheter is malfunctioning in this case. So before thinking about dialysis, you should flush this Foley catheter. This is a very important point. Presence of Foley catheter does not exclude urinary obstruction, and it's always a good idea to perform Pocus assisted physical examination and rule that out. So that's a simple question and can be quickly answered at the bedside using Pocus. And what is other major question that we have in any patient with AKI? It's about fluid management, right? So should I give fluid to this patient with AKI? Should I remove fluid from this patient? Because some patients may have congestive nephropathy because of fluid overload and cardiorenal syndrome. Those patients' AKI improves as you remove fluid. Or maybe the pump, which means the heart, needs help as an inotropic support for you to properly perfuse the kidney. And once you answer that initial set of questions, you have further questions. Did I give this patient adequate amount of fluid, or did I remove adequate amount of fluid from this patient? Or if the patient is on renal replacement therapy, is my ultrafiltration prescription appropriate, and so on. All these are common questions we have, and without point of care ultrasound or objective data, we rely so much on empiric decision making. I'll tell you a story. It's the blind man and the elephant story. So it's a small story of a group of curious blind men who have never come across an elephant before, and who learn and imagine what the elephant is like by feeling it and touching it. And each blind man feels a different part of the elephant's body, just one part of it, and tries to describe how an elephant looks like. So for example, this guy here feels the tusk of the elephant and says elephant is like a spear. And this guy feels the trunk of the elephant and says elephant is like a snake. And this guy feels elephant's ears and says elephant is like a fan. This guy feels the body of the elephant and says elephant looks like a wall. And this guy feels the elephant's tail and says it must look like a rope. And this guy says it's like a pillar. So the point is, I mean, first of all, these are blind people and they are not looking at the entire elephant. So they are looking at only a part of the elephant and trying to describe how an elephant looks like. And you can apply the same analogy for blindfolded physicians who are making empiric decisions at the bedside based on one particular criteria. For example, this guy here says, hey, the patient has AKI and urine sodium is less than 20. This must be pre-renal. So let's give fluids. Is that always right? May not be, because even in congestive nephropathy, when there is renal venous congestion affecting kidney perfusion, your urine sodium is still less than 20. Or in intra-abdominal hypertension, where the treatment is the relieving of intra-abdominal pressure, even then the urine sodium is less than 20. Giving fluids might not be helpful in that case. And this guy here says, the patient is hypotensive, give fluids, which may not be always right. For example, you have a patient with right ventricular failure and the interventricular septum is compressing on the left ventricle, and which is what causing hypotension. And if you reflexively give fluid to this patient, that interventricular septal flattening or pressure on the LV is more pronounced and the cardiac output further drops and the patient might die. So that can be potentially a serious consequence. And this blindfolded clinician here says the patient has AKI, just patient has AKI, give fluids. And this guy says lactate is elevated, give fluids. This guy says lungs sound clear to me on auscultation, give fluids. This guy says documented fluid balance is negative, so we should give fluids. So like basically every piecemeal data in clinical practice tends to favor administration of fluids, which may or may not be the appropriate step. And even the documentation is not always right. And we all have seen several cases, especially in non-ICU settings, where there is a discordant data. For example, in this particular patient's case, you see the weight has dropped from 78 kg to 66.8, but the fluid balance is only minus 860. So what should I trust? The clinician is obviously confused. So here it's clear that we need some objective data at the bedside to properly assess a patient's hemodynamic status. So what is bedside hemodynamic assessment? So in bedside hemodynamic assessment, which is commonly called as fluid status, but hemodynamic is more accurate, we are looking at three things. How is the blood flowing forward from the heart, or the forward flow, or the cardiac output, because that's an important component of perfusing the organs. And you also want to know about the back pressures of the heart. For example, if the left heart pressures are elevated, that manifests in the form of increased extravascular lung water. In those cases, giving fluids would harm the patient than benefit. Similarly, you want to look at the right-sided pressures. If the right heart pressure is elevated, it manifests in the form of elevated right atrial pressure, and then that elevated pressure is going back into those organs, causing congestive organ injury. So it's very important to assess both forward flow as well as backward pressures. So normally, without Pocus, how do we do that? We use physical examination, and we tend to trust it a lot, but unfortunately, it's not that accurate. For example, a lot of clinicians try to assess cardiac output by feeling the patients and assessing the patient's temperature. If the patient is cool, they assume the cardiac output is low. If the patient is warm, the cardiac output is adequate or high. But in a meta-analysis, they found in 5 out of 10 studies, they found absolutely no correlation between temperature and cardiac output. And in 3 studies, they found only moderate correlation. And only in 2 studies, they found some decent correlation between cool temperature and cardiac output. So in real life, it's not really helpful. How about back pressures? For example, look at this 1989 study in a set of heart failure patients with pretty low ejection fraction of 18% and a mean pulmonary capillary wedge pressure of more than 22 millimeters mercury. And they found that the sensitivity of Rayleigh edema and elevated mean JVP was only 58% in these patients. That means you will miss a significant proportion of patients if you just rely on conventional physical examination. And in another systematic review, looking at how physical examination parameters compare in heart failure patients, they looked at all these things: S3 gallop, abdominojugular reflex, JVD, Rayleigh edema, S4 heart sound, and ascites. And only two parameters that had a decent likelihood ratio of more than 6 were S3 gallop and abdominojugular reflex. And ironically, their sensitivity is only 0.13 and 0.24. So which is essentially useless at the bedside. I mean, if you find them, that's great. So most likely the patient has heart failure. But if you don't find these signs, or you are not able to elicit these signs at the bedside, you might still be missing a significant proportion of patients with heart failure. And even physical examination tests, do we do them properly? For example, I asked on Twitter how many people actually assess jugular venous pressure the way it should be. As you know, it should be done using two instruments. You want to find the highest point of venous pulsations, and you want to see the height of that from the manubrium sternum, and you add 5 centimeters to that for the right atrial depth. And 62% of 756 respondents said they never use these two instruments to do this test in a proper way. And only 20% of the respondents said they always do this test like this, which is extremely small proportion of clinicians. So far we said that, of course, we definitely need some objective data at the bedside, and our physical examination is not really that great. So if you incorporate point of care ultrasound and perform a Pocus enhanced physical examination, is that better? So there are multiple studies that looked at that. For example, this meta-analysis looked at the comparison between Pocus and conventional physical examination to assess left ventricular dysfunction as well as valvular disease. So compared to auscultation, focused cardiac ultrasound substantially increased the sensitivity of both valvular heart disease and LV dysfunction at the bedside. And the specificity is also enhanced with focused cardiac ultrasound, but not so much compared to physical examination. Basically, what it means is if you find that thing on physical examination, find something, LV dysfunction or a valvular disease, yes, you are most likely to be correct. But if you don't find, you will miss a significant proportion of patients. That's a problem with lack of sensitivity of physical examination. And in a large cohort of dialysis patients, compared to lung ultrasound, the investigators found that the sensitivity of lung coracles is only 9%, peripheral about 3%, with a combined sensitivity of only 13%, which is extremely low. Again, in this study, the specificity was pretty decent for physical examination finding. How about in sick patients, critically ill patients? In a study of ARDS patients, the sensitivity of point of care lung ultrasound was substantially higher than both chest X-ray and physical examination for detection of pleural effusion, alveolar consolidation, as well as alveolar interstitial syndrome, that is pulmonary edema. So it's even better than chest X-ray. How about the comparison between chest X-ray and lung ultrasound in cardiogenic pulmonary edema? The lung ultrasound is much better in terms of both sensitivity and specificity compared to chest X-ray, even in this scenario, according to this meta-analysis of 8 studies. So basically, we are saying point of care ultrasound is better than your conventional physical examination, and also in selected cases, it might even be better than the traditional radiographic tools. And does Pocus change management? Of course, yes. For example, in this large cohort of like over 1,000 patients with shock, echocardiography was found to reduce diagnostic uncertainty or change management in more than 50% of cases. That's substantial, half of what we are doing. And in the study, echo was performed within 72 hours. So if echo was performed as soon as the physician see the patient, this percentage would likely be much higher. Because it's going to reduce diagnostic uncertainty by reducing the number of empiric treatments. If you do it after 3 days, you have already tried some empiric treatment. So in some patients, you would know if the treatment worked or not. And does Pocus reduce further imaging? Yeah, it does, and it might definitely reduce the healthcare cost burden in that sense, and it might actually be better in low resource settings where patients might have to wait significantly longer or travel longer distances to find places that do CAT scan or MRIs or further consultative imaging, like even echocardiography. This is a study that looked at it. There was this study of 518 patients admitted to internal medicine ward. They were randomized to usual care group or Pocus guided treatment group. And in the Pocus group, there was substantial reduction in the number of consultative imagings done compared to the usual care group, and mainly by reduction in the number of echocardiograms and chest x-rays. That's significant reduction. Again, contributing to betterment of healthcare costs. And while some people debate about whether should I do Pocus or not, I'll do Pocus if it improves mortality and so on, patients are doing Pocus. And if you don't learn, you lag behind. This is from a paper in ESC heart failure, where they looked at whether patients can perform their own lung ultrasound and report their findings to physicians remotely. That way, or share the images remotely. That way, the physicians can see them and change treatment if necessary. So that's been going on too. And one important thing when you are performing Pocus is, of course, we said Pocus is a component of physical examination, but that does not eliminate the need to save images. This is very important. Never perform phantom scans. Phantom scan is something that you take your ultrasound machine, you do something, say, yeah, I found something, pericardial effusion, LV dysfunction, whatever, but you don't document in the chart, you don't save the images. That means the experts cannot review those images. And in that case, like, experts have to do the study again to answer the same focused clinical question, especially if you're calling consults. Or sometimes, depending on the operator's expertise, the findings may be wrong. So it's always good to be reevaluate the findings and look at the images and provide feedback to the learners or trainees. And saving these images also facilitates billing practices if you are billing for the studies. And it's a valuable adjunct when you are trying to develop a training program in point of care ultrasound. And that also cultivates a sense of responsibility among physicians, because if you're not documenting anything, you can say whatever you want and put in the chart. But if you are saving the images, then you have that perception that somebody is going to look at those images. And if you're not confident, you won't be overconfident. You'll make an effort to learn new things and get better. So let's see a few examples. Like I said, I mean, the purpose of this lecture is not really going into technical details, but again, like, I want to give some glimpse of some common sonographic applications. So you have a patient with AKI, and your question is, should I give fluids? And what are we looking at here? So this is towards head, this is towards feet, and we are looking at the inferior vena cava. So this is the inferior vena cava, which is a tube connected to the right atrium. So here is the right atrium, and here is the liver. So because this is a tube connected to the right atrium, if the right atrial pressure is elevated, the tube is big, and with inspiration, it does not collapse much. What does inspiratory collapse mean? During inspiration, blood is sucked into the right atrium, so the vessel collapses in normal state. Like, as you are seeing in this image here, you measure the diameter and collapse approximately 1 to 2 centimeters below the hepatic vein IVC junction, and normally it collapses by more than 50% when the patient takes a deep breath. So if the right atrial pressure is elevated, the vessel is pretty big, doesn't collapse much. If the right atrial pressure is not elevated, it's something like this, which is relatively small, less than 2.1 centimeters, and collapses more than 50%. So coming back to our patient, so this IVC is here, looks pretty big. Like you can see the scale here, it's bigger than 2 centimeters, and it's barely collapsing with inspiration. So the right atrial pressure is elevated. So if the right atrial pressure is elevated, that means the patient is unlikely to benefit from fluids, and you can further increase the pressure in the atrium by giving more fluids, and that's going to travel backwards into the kidney and cause congestive nephropathy or worsen AKI basically. And here is another patient with acute kidney injury, and here we are doing a lung ultrasound. What are we looking at here? We see some bright line here, and we see all vertical artifacts. Bright line vertical artifacts. What do they mean? So normally you cannot ultrasound the lung as you ultrasound liver and find a tissue like architecture. You can't do that with the lung because lung is filled with air, and air reflects or scatters ultrasound, so you can't see anything beneath the pleural line. So all you would see are horizontal A lines when the lung is filled with air, which means that's good, that's a normal lung. And you will see vertical lines or B lines when the lung has a pulmonary edema. So B lines represent thickened interlobular septae, which is typically with fluid. It can also happen with fibrosis. So that's why B lines are non-specific. But in nephrology context, commonly we are talking about pulmonary edema. So think of vertical artifacts as indicative of pulmonary edema. So going back to our patient, here we have the pleural line, and we have these vertical artifacts. So this patient has pulmonary edema. If you are finding this thing in the anterior zones, that means definitely the patient's lungs are full of water, and this patient is unlikely to benefit from fluids. And as you saw in the prior slides, and the physical examination is not really sensitive to detect that. You might ask, oh, if there is so much pulmonary edema, wouldn't I hear rales? Maybe or maybe not. And sometimes it depends upon the setting. Say you are in the ICU, there are a lot of machines beeping, maybe even in the dialysis unit. The dialysis machines make a lot of noise with all those alarms and stuff. So you might not be able to hear properly on auscultation. So these two are like pretty straightforward cases. So now you might think, yeah, I do IVC and lung ultrasound, so I am an expert in volume status assessment. That might not be appropriate, because let's think about this term volume status. Does ultrasound assess volume? No, right? Ultrasound only tells you the dimensions of the vessels. It tells you about the flow patterns if you use Doppler, and flow velocities on Doppler ultrasound, but it does not measure the volume. What do I mean by that? For example, let's take the context of inferior vena cava, or say right atrial pressure, which IVC tells you about. So what determines right atrial pressure? So here is the right atrium, right? And one thing is definitely volume. If you have excess volume, you have elevated right atrial pressure, fine. But there are also a lot of other factors that affect it. For example, how is the right heart moving, right heart contractility, and pulmonary status. Does this patient have pulmonary hypertension? Is there acute pulmonary embolism? All those things will raise the right atrial pressure. Also, if the patient has tricuspid regurgitation, that can raise right atrial pressure and also can dilate the inferior vena cava, even disproportionate to the rise of right atrial pressure. And it also depends upon the right atrial compliance, that is the stretchability of the right atrium, and it depends upon the venous compliance, and it depends upon the left heart function too. How is the left heart contractility? Is there a mitral regurgitation, diastolic dysfunction, and so on? Ultimately, everything has to travel to the right side, elevating the right atrial pressure. And it is also determined by intrapericardial pressure. So what if you have pericardial effusion and not fluid overload? So that also contributes to right atrial pressure. and it's also affected by intrathoracic pressure. For example, you have a patient with pneumothorax or a big chest in an obese patient, that also contributes to right atrial pressure. And what if you have increased intra-abdominal pressure? That can compress the inferior vena cava and make the vessel appear smaller even when the right atrial pressure is elevated. So we have to take into consideration so many factors and interpret IVC in the appropriate clinical context. In reality, because all these dynamic factors affect right atrial pressure, the right atrial pressure only measures the volume state only when the heart is stopped. So the term volume status assessment is essentially meaningless in a living patient. Think about it. Okay, fine. You didn't give fluids to a patient who has B-lines or vertical artifacts in the lungs. So that's it. Is your job done? Do you have to look at anything else? So here this patient has this nice pleural line and a lot of vertical artifacts. Say assume whole lung ultrasound shows this. But the cause of these B lines or pulmonary edema might be in the heart. If you don't treat that underlying pathology, the patient will keep developing pulmonary edema no matter how much diuretics give. So now look at this patient's heart. So we are looking at left ventricle, left atrium, and this is the mitral valve. It looks kind of funny here, and there is something on the valve here. And when you put color, there is so much mixed color flow going back into the left atrium. This patient has severe mitral regurgitation from this mitral valve vegetation, and which is causing pulmonary edema. So you have to treat what's causing pulmonary edema. Or sometimes you might find a heart like this in a patient with pulmonary edema. So here, this is the left ventricle, this chamber here, and you can see that it's barely moving. So it's a case of severely reduced EF, and maybe this patient requires inotropes, or if this is a newly reduced ejection fraction, you might have to call cardiology for proper ischemic workup and maybe cardiac catheterization. So it's very important not just to be very binary and narrow tunneled in terms of making your diagnosis using Pocus. That's why isolated Pocus is never good. Also remember that hemodynamics are dynamic, and a recent echocardiogram, just because the patient has a recent echo a week before or a couple of weeks before, it doesn't eliminate the need for Pocus. Even if the patient had an echo yesterday, today something might have changed, and you might have to look at the heart again using Pocus. That's important to note as well. Okay, and this is another case. So you did not give fluids to a patient with a plethoric IVC. So is there anything else to check on Pocus? Again, of course, now you know the right atrial pressure is elevated, but as we just talked about, right atrial pressure can be elevated because of a lot of things. So you have to look at the heart. So when you look at the heart, what do you see? So this is the left ventricle, this is the right ventricle, left atrium. And surrounding the heart, you see something black. Here also there is something black. So black is fluid on ultrasound. So this is a case of pericardial effusion. Let me erase the ink. So is there anything else you want to note? You want to see how the right ventricle is behaving there. And as you know, right ventricular collapse during diastole is consistent with tamponade physiology. And how do you know what is systole, what is diastole? Here is the mitral valve. So if that collapse is happening when the mitral valve is open, that's diastolic collapse. So let's pause this image and see. So here the mitral valve is open and the RV is collapsing. So this patient has tamponade. And to develop tamponade, you don't need to have a huge pericardial effusion. Sometimes you can have a mild to moderate pericardial effusion, but can still develop tamponade, especially if you are doing aggressive diuresis or ultrafiltration. For example, you have a dialysis patient, mild to moderate pericardial effusion, but you don't know. You just perform IVC ultrasound, see IVC is pretty plethoric, and write for 3-4 liters of ultrafiltration. And what happens during ultrafiltration during dialysis? You remove the fluid from within the heart. Basically, you are reducing the intracardiac pressure in relation to pericardial pressure. So the pericardial pressure is increasing relatively, causing or precipitating tamponade. So that's why it's important to look at the heart always. Never perform isolated IVC ultrasound. And let's look at another small case. So here you have a patient with hyponatremia, and physical exam shows this. Physical examination, I mean Pocus, shows this. Here you're looking at an inferior vena cava. It's a vessel connected to the right atrium, and you can see it's very small IVC that's 100% collapsible. What does it tell you? We said a small collapsible IVC tells you that the right atrial pressure is not elevated, but that does not mean volume depletion, right? Because in normal scenario, your right atrial pressure shouldn't be elevated. Normal right atrial pressure is 0 to 6 millimeters mercury. So it doesn't differentiate between euvolemia and hypovolemia. So if you just assume that this patient has hypovolemic hyponatremia based on this finding and give fluids, and some patient who is euvolemic and who has a very high urine osmolality might actually drop their serum sodium level, then what should you do? You should look at the heart. If you are doing advanced Pocus, you can assess actually the stroke volume. I'm not going to delve deeper into like how you do that, but in general, like if you assess the blood flowing through the aortic valve, you get a trace like this in each systole. So if you're able to trace this waveform, the machine gives you a number called VTI, or velocity time integral. So this is time, and this is the velocity scale, right? So you do the integral of velocity and time, you get a number in centimeters. A normal velocity time integral is about 70 to 23 centimeters. This patient has 28. So actually the stroke volume is higher than normal. In this case, it's very unlikely that the patient is volume depleted. So this patient doesn't have hypovolemic hyponatremia. So yeah, it's important to look at the heart, and sometimes using Doppler to assess the blood flow. And it's also important to note that the B lines that you see on the lung are non-specific. I briefly mentioned that before, but in general, just know that these are resultant of interlobular septal thickening, which can be because of cardiogenic pulmonary edema or because of pneumogenic pulmonary edema as an acute respiratory distress syndrome, or interstitial pneumonia as in COVID-19, or it could be a manifestation of diffuse alveolar hemorrhage, which is very pertinent to nephrology. You can have a patient with AKI and B lines in the lung. You can't just assume that they are because of fluid overload in AKI. It could represent pulmonary renal syndrome, interstitial lung disease as in fibrosis, or some physiologic B lines here and there can be seen in dependent zones which are physiologic. And there are certain clues on lung ultrasound to assess that, such as the irregular pleural line. But the point is for you to know that B lines are non-specific, like IVC is non-specific for volume. Another myth that frequently goes around in nephrology communities that IVC ultrasound is a good tool to predict fluid response. So is that true? No, it's just an educated guess. Because what does fluid responsiveness mean? It means that if you give fluid to the patient, they will mount an additional stroke volume in response to that fluid. That's fluid responsiveness. If you think about the Frank-Starling curve, here is the cardiac output and here is the preload or central venous pressure, and you can use inferior vena cava ultrasound as a surrogate for central venous pressure. If the patient is operating here on the steep portion of the Frank-Starling curve, the right atrial pressure is low, that is the central venous pressure is low. That means IVC is small and collapsible, and the patient will be responsive to fluids. That's fine. On the other hand, if the patient is operating here on the flat portion of the Frank-Starling curve, the patient won't respond to fluids, and you can assume that their CVP is high. That means the inferior vena cava is plethoric, that is dilated and non-collapsible. So at extremes it's useful, but in the middle portions of the Frank-Starling curve, you cannot predict a patient's response to fluids just by knowing a value of central venous pressure. So that's a big gray zone. And also not everybody's central venous pressure, everybody's Frank-Starling curve is the same. Some patient's curve is extremely right shifted. What it means is this patient with the green curve can tolerate maybe 1 liter of fluid, without any problem, without raising central venous pressure. But this patient on this purple curve may only tolerate 300 cc of fluid. So every patient is different, and it's not really possible to predict fluid responsiveness using IVC ultrasound. And say if the patient is fluid responsive, what next? Some physicians say fill the tank. Because the patient is fluid responsive, you should give fluids. No, that's not correct ideology, because fluid responsiveness is a physiologic state, and if you're exhausting fluid responsiveness by giving fluids, you are pushing these patients onto a pathologic spectrum. So fluid responsiveness is not an indication for fluids. And also, what many people don't realize is that fluid responsiveness does not mean absence of congestion or absence of elevated back pressures. They can definitely coexist. For example, in this relatively recent study, they found that both in fluid responsive and unresponsive patients, more than half of these patients had some signs of congestion. So they can definitely coexist, and giving more fluids would harm these patients. Okay, so next part of the question is, so far what we said was like, yeah, looking at the IVC and lung is definitely helpful, but there are a lot of scenarios where they are not helpful also, where you have to look at the heart and get more information, and in some cases you have to do Doppler assessment of the heart. And coming to another scenario, you have a plethoric IVC and you decide to remove fluid based on cardiac Pocus also, and clinical context. So you have excluded pericardial effusion, maybe the patient has some pulmonary hypertension, but what next? What else can you do or to monitor? That's called VEXUS, or venous excess ultrasound. Basically, we said that if the right atrial pressure is elevated, the IVC gets dilated, but as the pressure is transmitted backwards into these systemic veins, intrarenal vein, hepatic vein, portal vein, their blood flow is altered, which can be elicited by Doppler ultrasound. And you can use these parameters to monitor response to treatment, not just diagnose something, not just diagnose that there is venous congestion, but also see how these waveforms change over time. So VEXUS is a whole big topic. Just to give a brief idea, I'll just show an example of a portal vein pattern. Normal portal vein Doppler is pretty continuous like this, but when you have severe congestion, it becomes pulsatile. So here I saw a patient who has a documented fluid balance of positive 12 liters. On first exam, the portal vein is very pulsatile. That means there is severe congestion. So I put this patient on continuous renal replacement therapy, and this is a fluid balance from prior examination. So we removed about 4 liters. So it's still pulsatile, but not as bad as before. And we remove more fluid, and it becomes almost normal with little bit of pulsatility. But something happened and the patient got some fluid and it became more pulsatile now. And we remove more fluid, negative 5 liters from this prior exam, and it has completely normalized. Unfortunately, the patient was taken to the operating room and got a lot of fluids and then became very pulsatile. And again, if we removed fluid, it came back to normal. So it's like a visual guide for us at the bedside to monitor the efficacy of decongestive treatment. So basically, I just wanted to give a glimpse of how hemodynamic assessment works at the bedside. And we talked about forward flow. We talked about elevated left heart pressures and elevated right heart pressures and consequences. So basically, we are evaluating the whole hemodynamic circuit and should not rely on individual pieces. And ultimately, to perform Pocus effectively and help patients, you need proper training. Training is the key, and that's how you become competent. You attend a workshop by a professional society, and that's just a starting point. Just by attending a workshop, you won't become a master. You need to go back to your institution and keep practicing with some oversight, with expert oversight. That's when you ultimately become an expert. Because a fool with a tool is still a fool. You can have a great ultrasound machine, but if you cannot properly interpret the findings in the appropriate clinical context, it's still useless. With that, I'll finish. Thank you so much for having me. And this is my photograph with Professor Bastos at National Kidney Foundation meeting. I want to congratulate Brazilian Society of Nephrology and Dr. Bastos and his team for this undertaking this amazing initiative of establishing a Pocus committee within the organization. And all the best. Thank you so much.